अस्सलाम वालेकुम जी। डॉक्टर रेहान उमर के साथ आज हम एक इम्पोर्टेंट टॉपिक पे बात करेंगे जिसको हम कहते हैं ओबेसिटी के बारे में। सो ओबेसिटी हमारे मुल्क में एक स्टिग्मा है। इट्स मोर ऑफ ए सॉर्ट ऑफ ए टैबू फॉर आवर पेशेंट्स हु fail to discuss their management strategies and instead keep the stigma to themselves, ultimately resulting in all sorts of cardiometabolic complications. And so आज मैं जो आपको बताना चाह रहा हूँ how to start a conversation about obesity with your patients. So before initiating the talk on obesity, one should be fully aware of the fact that obesity should be recognized as a complex, chronic, and progressive disease requiring medical intervention. And it has been classified in the CDC that it is a disease, it's a chronic disease that has to be taken care of. And it is associated with multiple and serious complications and comorbidities. There are many tools available in the market in the healthcare industry for patient management, and addressing the discussion with the patient remains the first step. जब तक हम पेशेंट से बात नहीं करेंगे हम ज़्यादा तरीके से कामयाब नहीं हो सकते। जिस तरह पेशेंट से बात करते थे कोविड के ज़माने में, जिस तरह हम बात करते हैं पेशेंट से डायबिटीज़ के हवाले से, उसी तरीके से हमें वी हैव टू कम इन द फुट ऑफ द पेशेंट एंड स्टार्ट थिंकिंग फ्रॉम द हॉर्सेस माउथ कि डस patient क्या सोचेगा? Does my physician have all the responsibility for my weight reduction program? Is he the one who has got the role to play? Or do I need to speak with my physician for my weight loss? And ऐसा तो नहीं कि ये मेरे लिए शर्मिंदगी का बाज़ बने. So whenever the patient comes to you, it is the prime responsibility of the physician that he has to go for the 5 A's in patient's management. When it comes to obesity, there are 5 A's in management strategy. And the first step in that strategy is always to ask permission. ऐसा नहीं कि एक पेशेंट ओवरवेट या ओबीस आपके सामने बैठा है, आपने छूटते उस पर लेबल लगा दिया आप तो मोटे हैं. So this sentence of yours can act like a bomb for the patient. He can either develop severe depression or he can even have suicidal ideation if he listens to this kind of rubbishly, utter rubbish to begin with from the physician perspective. So the physician should always ask for permission. Would it be all right if we discuss about your weight? The second is when you have taken the permission, the second is assess their story. Let the patient talk about his weight gain journey so that you can pinpoint those areas which could be helpful for the patients to lose his weight. And then after listening to his story, the third is advise on management. So now it's your task from the other side of the table to discuss the management strategies. It should never be one-sided. Management strategies should always be across the board. Both the sides should come up to a definite plan for patient management, and this is known as agreement on goals. This is the 4th A. And then the 5th A is we should assist our patient with different drivers and address the different barriers that are responsible for the lack of weight loss, and we shall all start talking about those barriers. So this is very important. We know that the prevalence of weight discrimination is of higher risk among heavier individuals, and it takes about a decade for the patients to realize about their obesity and a problem associated with obesity. For example, if a patient was obese at the age of 29 and he realized about that at the age of 29, he'll come to the doctor at the age of 41 to discuss about his weight loss, and this has been labeled as delay to medical advice, that our patients keep on falling about that. So next comes the mythology or the myths. That the patient usually thinks that if he or she would eat less and move more, the patient or he or she would lose more weight. So it is the basis for the maintenance of stigma in medical management. The patient doesn't come to go to the doctor. It is a source of learned helplessness and eroded self-esteem in individuals living with obesity, and it assumes all individuals are able to achieve what is recommended of them, that is the willpower. So willpower that is achieving their ideal body weight through their willpower, eating less, moving more is a myth. And they should realize that it's not a behavioral issue when it comes to dealing with obesity. It has its own set of management protocols, that is physical activity, medical adherence, medical nutrition therapy, on top of psychological intervention, number one, number two, pharmacological therapy, and if everything fails, then these patients should be referred for bariatric surgery. It's very important. So, question, can you achieve your ideal or goal weight by eating less and moving more? The answer is no. You have to have an integrated approach. So asking permission is very important, builds patient-doctor relationship, importance of repetition of messages, that is the SSD history, and telling them, and then the three pillars of management is psychological issues, medications, and bariatric surgery. So the last point of my today's talk is time tagging. Patient कहता है आपसे जनाब मैंने 3 महीने में वजन कम कर लेना है. Absolutely absurd. There should not be any time tagging. It's not finding the time you think you need. It's using the time you have. So always tell the patient, do not tag your time. Always ask permission before asking your patients. And then of course, make the patient realize that there is actually hope regarding obesity management. So this was my first talk on obesity. And if you are interested in further management issues, I'll get back to you very soon. So obesity is a chronic disease. It has good management strategies available in the market in order to get rid of your extra fat. And number 3, do not become doctors yourself. Thank you very much.